So the first question we wanted to know is that we know you have conducted extensive research on imaging techniques in prostate cancer. So how do you see the role of cutting-edge imaging techniques, such as prostate-specific membrane antigen PET involving prostate cancer diagnosis and management?
So there obviously were in prostate cancer like really two main paradigm shifts using imaging. The first one being MRI for the diagnosis of prostate cancer, getting from, let's say, a by chance diagnosis, hoping you stick the needle at the right place, to something we can see and drive a needle to a target. That substantially increased the reliability of the diagnosis and hopefully also the risk of finding non-significant disease. So that's really a game changer. The current issue we have is quality assurance and having that available on a general population, that the prostate MRI is basically everywhere a high quality MRI. We need to go the same way as it was done with breast cancer, where nowadays screening is done. But only done in certified centers that do provide the right quality, the expertise, and the knowledge. And we need to go the same way for prostate cancer. And once we have this, I'm pretty confident that we will substantially improve the benefit of early detection and screening of prostate cancer. And then the second paradigm shift is molecular imaging, where we started with colon PET, which is just like a metabolite, and then came to a small molecule that is linking to the prostate-specific membrane antigen, the PSMA molecule on the cell that is overexpressed in prostate cancer. And that allows us to go beyond anatomical imaging to understand what is going on the cellular level, helping us to better identify the true spread of the disease, its localized regional disease, metastatic disease. And that is something we started using in biochemical recurrence. It now extended to the initial staging and is also used now for treatment of advanced disease, especially castrate-resistant disease, with the use of PSMA radioligand therapy. And the advantage is that we have here a technique that allows us to do a treatment and diagnosis at the same time, theranostics, and that was probably in the near future to come. We will expect major changes based on this. The treatments will come earlier in the lines of the treatment, and we will identify those patients who will best benefit, probably using imaging for this, identifying those candidates who might get the best benefit out of this PSMA platform treatment and diagnostics.
Okay, thank you so much. And beside this, and minimally invasive surgical techniques are transforming urology. And what advancements in robotic-assisted prostate surgery do you find most promising? And where do you see room for improvement?
Also here we had maybe a little bit later or longer away than the imaging, a major shift, especially in oncology, where we basically switched entirely to robotic surgery with the multi-port system, helping us to obtain the same advantages as we have from open surgery, but being minimal invasive. That's what we would like to have, with all the advantages that might generate this minimal invasive approach for our patients. And at least in Europe, just recently, Intuitive launched the single port platform, which probably helped us to be even more minimal invasive. And I think that will be also a game changer, probably as much as the multi-port system was 20 years ago. And this will become probably the standard in the next 10 to 15 years. That's one thing. And then the additional step that will come add to it is probably the augmented reality. So we will be able to have imaging information being superimposed on the screen where we do surgery, allowing us to better identify where the organ is, where the disease is, how to work around it, how to individualize the dissection, improve on the one hand the oncological outcome, on the other hand the functional outcome, special relevance for prostate cancer, obviously, where we would like to know where the disease exactly is inside of the prostate, allowing us then to fine-tune and to individualize the dissection around the cancer, at the same time maintaining the nerves and the sphincter, the muscle responsible for the continence, achieving the aims of being very effective with cancer control, at the same time allowing the patients to maintain urinary continence and erectile function. So I think both together, the single port approach and then the augmented reality will be the improvements we see in the near future. I'm not that sure that AI, artificial intelligence, in the next years to come, but yeah, the speed is amazing, and maybe we will see in very little time substantial changes and improvements in technology brings us a step forward also for surgery.
Okay, thanks for sharing. It gives a direction for the surgeons, especially in mini-invasive surgery. And what do you see as the next breakthrough in prostate cancer research? And just you referred to the artificial intelligence. Do you think it's will be the next breakthrough?
Yeah, you're raising an important point. I think indeed, like prostate cancer research, probably because it's the most frequent disease, so it's an easy one. But I think the next step we will go is indeed integrating artificial intelligence into our research. It's better to understand the data. Obviously, genetics or genomics will also be very important here. And one reason why we were so far unable to go forward with genomics is probably because there's so much information in there that for our brain, the way we analyze data so far, it is impossible to identify the pattern that provides us with the right answer. And I think AI will be able to recognize that pattern and be able, with this basically endless amount of information coming from genomics, to get some relevant information out of it.
Okay, thank you so much. And I believe it can enlighten all the surgeons, and the topic is very important for our patients too. And if you could initiate one global initiative to improve prostate cancer outcomes, what would it be focused on?
It gets, let's say, several facets. So I would say what we would need is, as for MRI, probably we need to have quality assurance. We make sure that the rules that we have and the best we can do is applied in a systematic fashion. And this would probably go via centralization on one hand side, and then on the other hand side, also quality assurance, testing what you're doing, measuring what you're doing, PROMs, for example, patient-reported outcome measures, to really understand if the patient receives the treatment the patient expected, that the patient is happy or unhappy with the treatment, and then doing everything to obtain a satisfied patient getting the kind of treatment he was wanted to have and expecting to have. And this applies for diagnostics, very easy at the very beginning, for local treatment, for active surveillance. It applies for more advanced disease, for radiotherapy. I think we have a quality issue throughout the entire disease story. Like nowadays, we have for advanced prostate cancer, for example, and metastatic prostate cancer, the doublet treatment combining conventional ADT, androgen deprivation therapy, with a next generation hormonotherapy. That should be given to all patients, basically. And still, in many countries, this kind of treatment is not provided, not given to the patient, whatever the reason is. But if we would centralize and make sure that we really measure what we're doing, probably would do a major currently available treatment options in a systematic fashion in the optimal way, would probably bring more improvements for our population with regards of cancer control and survival than any new drug that is about to come up and being commercialized. We just need to use what we currently have, and I think we will have substantial improvements for our patients.
Okay, thank you. That sounds great. And the initiative will surely benefit the patients, I think, and also improve outcomes. And the last but not the least, as we know, you serve as a co-editor-in-chief of European Urology Openness Science. And do you have any constructive suggestions for journal managing or other aspects?
So the very first one is obviously it's a teamwork. So you need to have a reliable, motivated, great team to run a journal. And these are especially the associate editors, And then they need also to have a great team of reviewers. So you cannot do that by yourself. It's for sure a teamwork. And setting up this team is really the fun part of it, and make it run and see that everybody works together. That is actually what you take as a joy out of the management of a journal. Specifically for the European Urology Open Science is that it is an open access journal, which I think the more you think about it, really generates more advantages than disadvantages, where you need to pay for processing the article, which finally renders available for everybody. And if you compare the amount of downloads, citations, and consideration of an article that is open access versus an article that is blocked by paywalls or by a library, whatever, you can substantially increase the access to the article, the use of an article. Your research will be spread easier, and that's what an author would like to see, a researcher would like to see. And if we look at how we consume media nowadays, be it music or videos, you used to buy them, the CD or an LP, to listen to the music. Nowadays, you can basically get it for free wherever you are. And maybe we need to go the same for research and scientific publications. We need to recognize how media and information is consumed nowadays, and we need to adapt to this, because we cannot keep on an old-fashioned way of providing information when all other ways of getting or providing information completely change in the meantime. And the open access obviously is one of the tools that allows us to achieve that, in addition to the advantages you can generate with the availability and distribution of your research if you go this way. Obviously, I'm biased, but I'm nowadays a convinced open access article processor. Let's just call it this way.